name is LaShonda Davis, and I am a member of the NAACP Health Committee, Richmond, California branch. Over the next few weeks, the Health Committee will be sponsoring a series of conversations with practitioners and educators regarding coronavirus, the virus that causes the disease COVID-19. As we transition to October, which is Breast Cancer Awareness Month, the Health Committee thought it would be fitting to begin the series with a practitioner whose background and scholarly work covers the cancer continuum. From basic science to clinical care as a colorectal surgeon, as a researcher in cancer disparities, and with extensive training in health policy. Before I begin our conversation with Dr. Kim Rhoads, I would like to take a moment to share with you some aspects of her education and some of her accomplishments. Dr. Rhoads attended UC Berkeley and received her BA in linguistics. She earned her medical degree, University of California, San Francisco, a Master of Health Science at UC Berkeley, Master of Public Health from Harvard University School of Public Health. Currently, Dr. Rhoads is at University of California, San Francisco as Associate Professor of Epidemiology and Biostatistics. She also serves as the Associate Director for Community Engagement at the UCSF Helen Diller Family Comprehensive Cancer Center, where the objective is to eliminate the inequities that lead to cancer disparities in Northern California. She's also the director of Umoja Health, which is a community-run COVID-19 testing and vaccination initiative where all services are provided by the community partners in Oakland. It is a pleasure and an honor to be in conversation with you, Dr. Rhoads. Good evening. Thank you for speaking with us today. Would you like to just say some opening remarks before we start with some questions?
Well, thank you so much for having me and for covering the intersection of COVID and cancer. I know that people who are journey probably have a lot of questions, even on top of questions that people might have about vaccines or about just COVID infection and how to protect ourselves. So I think this is a really important topic. So thanks for welcoming me to this space.
Perfect. All right. So most of the questions we have came from individuals who are actually living with cancer or who are cancer survivors, or they are caregivers. They provide some sense of support for someone who is living with cancer. So one of the first questions I'd like to start with is, as a cancer patient survivor, if I am not vaccinated, how does this impact my treatment plan?
So not being vaccinated should not directly affect your treatment plan at all. What I'm not sure of is whether or not people feel like they might be refused care, or they might not be able to come into the healthcare setting or the hospital. But currently there are no mandates that the hospitals have for patients to be vaccinated. So if you are unvaccinated, your care plan would proceed as normal. I believe that, you know, based on what we know about the risk of the severity of a COVID infection in people with cancer, which is an immune compromised condition, it's likely that the oncologist will discuss vaccination and talk about the timing of vaccination if the patient is interested in getting vaccinated. But they would do that because they understand the risk of being severely ill with COVID or with passing away from COVID in the setting of cancer is high.
Right, right. So that brings me to the second question, which is kind of piggybacking on what you just pointed out. So the second question is, am I able to undergo chemotherapy and radiation without being vaccinated? How would you approach that question?
Yeah, so you can get chemotherapy and radiation despite not being vaccinated. It's important to note that cancer in and of itself is an immune suppressive condition because your body's kind of, busy doing other things. But chemotherapy further and very deliberately reduces the immune system even further. And there are very, some specific chemotherapeutic agents, the immune checkpoint inhibitors like Keytruda and Opdivo. You may have heard of some of those from TV ads. Those kinds of chemotherapies are particularly risky for people being treated with cancer and the risk of having a severe COVID infection and the association with death in patients who were getting immune checkpoint inhibitors was noted in a study published in 2020 in Nature to be quite high, significantly higher than all other subgroups of people, even those who just have a diagnosis of cancer.
Right, so that is definitely something we need to make sure the community knows. All right, so moving to kind of the communal perspective. So if a person is vaccinated, what is being done, if you know, in treatment centers to reduce potential exposure by others who may not be vaccinated? Any insights about what is being done? And I'm not really certain what the being done looks like, but if you could give us some food for thought on that.
Sure. So most hospitals and healthcare centers are doing COVID mitigation measures because they are not asking patients to show proof of vaccination, or, as I said, there's no mandate in place right now to say that you have to be vaccinated in order to obtain care in that particular setting. So they're doing the kinds of things that we were doing before vaccination. For example, they're limiting the number of people who can come into the waiting room, for example. They are ensuring that people are socially distanced as much as can be. And there, of course, they are requiring mask wearing because that's part of the culture of being in a hospital. At some point or another, if you work in a hospital, you've probably worn a mask just because it's part of the culture. So, and then having a lot of hand sanitizer available in places where it might not otherwise have been available to the public. So they're doing mitigation measures to try to reduce the spread of COVID in most healthcare settings. Again, they're not mandating that you're vaccinated or that you show proof of vaccination. So those are the things that they can do to reduce the spread of virus.
Thank you. Now to the next question. Since the booster has now come out, and that's kind of the latest dialogue about who should get it, when, and so on and so forth, what are your thoughts about individuals who are cancer survivors getting the booster and or those who are currently living with cancer? Should they get the booster? Should they not get the booster?
Yeah, so booster shots are right now have been approved by emergency use authorization by the FDA. The recommendation from the CDC is that those shots only go to a select group of people. And that list of people includes, I would say, first off, the thing to know is it's only for people who got Pfizer the first time around. It's not for anyone who has gotten Moderna or Johnson & Johnson. There have been no recommendations on Moderna or Johnson & Johnson. So if you had Pfizer, 6 months ago, completing your second dose 6 months ago, and you were over age 65, then you automatically qualify to get a booster shot, as has been, authorized and recommended by the CDC. There are some other categories of people under 65 who are also recommended to get the booster, and those include people who have certain medical conditions which are considered immune compromising. So taking chronic steroids for inflammatory diseases, having HIV or AIDS, being on active chemotherapy, or having an organ transplantation. So this criteria is going to be loosely interpreted in a number of counties, and I can speak for Alameda County as well as San Francisco County. I'm not quite sure what the recommendation is in Richmond, but people who have cancer or history of cancer are considered in the medical community as immune compromised. So even if you're not on active chemotherapy, you do fit under the category of people who are approved to be having a booster of Pfizer at this time. So I do recommend that folks take advantage of the booster shot. If you've already been vaccinated, the idea is that the immunity that has come from the Pfizer doses starts to lower or wane. You might hear that word wane after 6 months. And so the idea here is to engage your immune system and try to rev it up so that if you do encounter COVID, that your body is ready to deal with it and in a timely fashion and with enough vigor that your immune system is really ready to go.
Okay, great. That gives a lot of clarity, because there has been a lot of talk in the community about who should get it, who shouldn't, why should they even get it. But that point you made about it only being for Pfizer, I think is critical for people to know. So the next question, what has been the biggest risk or lesson learned about cancer treatment during the COVID-19 pandemic?
I think the early studies in the pandemic, a lot of cancer centers shifted from thinking about cancer in isolation to thinking about how COVID is impacting cancer. So I think there are two things that are critically important. One is around screening and prevention and early detection. And that is the fact that because of COVID, people have not sought the medical care like they might normally do. And so what we're seeing now is people presenting with cancers that are very advanced or late stage, which are more difficult to treat and harder to survive. And that's because the routine screening that people were used to doing has kind of halted during COVID. And I think a sub point to that is that although right now it looks like the rates of screening are coming back up to baseline or back up to where they were before COVID, that's not true in all communities and all populations. And so the communities that are not bouncing back as quickly are those with Medi-Cal insurance or Medicaid insurance, as well as in the African-American community. And so the concern is that the disparities that we have seen in cancer before we saw, them in real time with COVID, we're going to start to see more of that. We're going to see some of the gaps widen because of the later stage at the time of presentation for the diagnosis.
That's interesting. Okay, so
the second point I was going to make is just I think the surprise for everyone looking at the data around cancer and COVID and how severe the disease can be, and really seeing that that cancer does by itself add a layer of risk to how severe the disease is going to be and whether or not you survive.
So Wow. Yes. So I'm thinking, what is it that we can do, given what you said about screening and prevention, early detection, kind of piecing those together where folks just haven't been able to get in to see their physicians or be consistent with finding out if they actually have cancer? How can we, really push to get people back up to a baseline in the communities that we're concerned about most? What should we as a community try to do?
Well, I think the first thing is just infusing screening and self-care and overall wellness back into the conversation. We've been so deeply embedded in a conversation about illness in the past 18 months and all the secondary consequences of COVID circulating around that results in other, more illness and morbidity in our communities. And so I think we have to start to focus on getting used to the fact that COVID's going to be around. We need to wear masks. We need to protect ourselves. Hand washing, social distancing, vaccination for those who are ready for that. But we need to also start to say, given all that, that's our new landscape. We need to get back to screening. We need to get back to primary care. And have that in the conversation. COVID has been dominating the conversation for 18 months, and it doesn't make space for these other pieces. For us with Umoja Health, with our pop-up model of being outdoors, which is the COVID safest, and trying to provide care outdoors, what we realized is a lot of care can be provided outdoors. So we're starting to, for October, you'll see at our pop-ups, we'll have a fair amount of breast cancer information. And we'll be trying to talk about that while folks are on site with us and reminding people. And in particular, because the booster shots will be in the 65 and up, as well as in some other vulnerable populations, those will be the folks that will be wanting to remind about breast cancer screening and early detection. And then, in our other months where we do observances like March for Cancer Awareness Month, we'll be working on strategies to actually get people screened using stool-based testing, which is a good first pass, because if that's negative, then you have a whole year before you have to do it again. If it's positive, then you do need to go on to a colonoscopy, but if it's negative, it means you don't need to go on to a colonoscopy. Okay. So there's a way to do that kind of work in the community outside of the walls of the hospital. People may not feel particularly safe going inside, or where there may be limited appointments.